Second class of drugs that we use in HIV or in our antiretroviral therapy is the reverse transcriptase inhibitors. Reverse transcriptase inhibitors. So once the virus has entered into the host cell, it must do uncoating following our PUSA process. Once it uncoats for HIV, the nucleic content is RNA rather than DNA. So the RNA must be converted to DNA before it can be inculcated or integrated into the host DNA. To aid the HIV virus to convert RNA to DNA is the enzyme reverse transcriptase. This enzyme we can inhibit directly by using the non-nucleoside reverse transcriptase inhibitors. They directly inhibit the reverse transcriptase enzyme, or we can indirectly inhibit the reverse transcriptase enzyme by using the nucleoside reverse transcriptase inhibitors. In this case, it is a competitive inhibition by using the basic building blocks. So there are two types of reverse transcriptase inhibitors. The nucleoside reverse transcriptase inhibitors and the non-nucleoside reverse transcriptase inhibitors. Now, of the nucleoside, which are the basic building block for DNA, we have those that have the phosphate group already attached to the sugar, which is the deoxyribose sugar, or even the ribose sugar. So it's attached. Those are referred to as the nucleotide because there's the attached phosphate group. It could be one, it could be two, it could be three phosphate group. But once there's the attachment of a phosphate, the nucleoside is reversed to nucleotide. When there is no phosphate, it is a nucleoside. In this case, has to be triphosphorylated. In the tide case, depending on how many phosphates are there, then the remaining to become triphosphate will be added. If it's a nucleotide, which is an indirect, just like we stated before, it's an indirect reverse transcriptase inhibitor, a competitive inhibitor. Examples are tenofovir, adifovir. So you note that when it's a tide, the fovir is used to identify. So tenofovir, adifovir. We said every other HIV drug that does not follow our rule we stated earlier is the nucleoside. For non-nucleoside, we said is the ver in the middle. So efavirenz, nevirapine, which are the ones we are using in Ghana. And this is where it directly inhibits the reverse transcriptase enzymes. So if we look at the nucleoside reverse transcriptase inhibitors, note that in this slide here, what I'm trying to do is I'm showing the analog of the basic building block, basic DNA block from which our drug has been made to look like. We talked about acyclovir looking like guanosine. The same way zidovudine looks like thymidine, stavudine looks like thymidine, didenosine looks like adenosine, lamivudine looks like cytosine, zalcitabine looks like cytosine, emtricitabine looks like cytosine, tenofovir, adifovir looks like adenosine. So you note that we are making the drug to look like the natural building block. And this is where the competitive inhibition comes in. So where the virus reverse transcriptase inhibitor the reverse transcriptase enzyme picks the true building block, thymidine, it will make proper viral DNA. But if it picks our drug, for example, zidovudine, it will make a faulty DNA. So how do these drugs work? We have said they must all be phosphorylated. So after the drug has entered into the cell, they must be converted to the phosphorylated form. In other words, they must be activated. And they are activated by adding 3 phosphate groups. So a triphosphorate form is the active form of the drug. And that is the one that competitively inhibits the reverse transcriptase enzymes. And once it's able to inhibit the enzyme, it results in terminating the DNA chain, Nucleoside reverse transcriptase inhibitors have been used for both HIV-1 and HIV-2 infections, even though we know HIV-1 is the predominant one, about 90-something% HIV-1. But the drugs are effective against both HIV-1 and HIV-2, the more virulent form being the HIV-1. Lamivudine and tracitabine have also been used in hepatitis viral infections. And zidovudine has also been effective, shown activity against the human T-cell lymphotropic virus. But we are interested in HIV, and so we will focus on HIV. The drugs are available orally, and as much as possible, we try to make them once daily dosing, 24-hourly dosing, to improve compliance for our patient. So all of them are available orally. We also have zidovudine available in an intravenous form. Once taken orally, the absorption and distribution is very good. Good absorption and distribution to body tissues is also good. Distribution goes even into the cerebrospinal fluids. For adenosine, it is advised that you take it on an empty stomach, for it's been shown that absorption is decreased by the presence of food. Clinically, these drugs have been used. Again, we are interested mostly in HIV infections. So zidovudine, for example, has been used to inhibit replication of HIV virus in infected individuals. It's been shown also to decrease the rate of clinical disease progression, and it helps prolong survival of our patients. Now, it also has effects in managing HIV-associated encephalopathy or thrombocytopenia, and it has been used to prevent mother-to-child transmission, which is also called vertical transmission. It's very effective, an agent in our HIV management, but we should note that the virus can rapidly develop resistance to it and should never be used as a monotherapy. So when we use it as a monotherapy, we encourage the virus to develop resistance to it. So it should not be used particularly as a monotherapy agent. Lamivudine is also useful for HIV virus, HIV-1, including those that have shown resistance to zidovudine. And lamivudine has been used for hepatitis infections. When used together with zidovudine, it has a synergistic effect or activity against HIV-1. So we normally combine these for what is called advanced HIV disease. Now, the combination also seems to help reduce the emergence of resistance to either drugs, especially to zidovudine. Didanisine, which we don't normally use in Ghana here, is also effective in slowing clinical progression of the disease in HIV-infected individuals. Should not be administered as a monotherapy, even though we could use it, but we don't encourage that. Again, like I said, for HIV, we don't encourage monotherapy in any way. So it could be administered monotherapy or in combination with zidovudine. And again, we have said we do measure body weight, very important. You have to give it per patient's body weight. All right. Zalcitabine is also available, has also been used for HIV-1, and it's also available in combination. We can combine with zidovudine. So in Ghana, we have this zidovudine with other combinations that we use in our management. It's not only the only drug, we can use other ones like tenofovir have also been used in combination, for example, with lamivudine. The adverse effect, because of the few that I picked, we just want to talk about adverse effect of those ones. So zidovudine, we have said, can cause myelosuppression. We've already stated that. It also causes GI intolerance. It can cause some headaches and insomnia, especially when you give it in the initial stage. But as you keep on taking the medication, it will stop. So that's the advice we normally give our patients. We encourage them that they will go through maybe a few weeks of this, and then it will stop. It becomes less and less. Another side effect that we've seen with zidovudine, thrombocytopenia. These are not common. These are not very frequent, but it can happen. Thrombocytopenia, acute cholestatic hepatitis, and myopathy. If you take lamivudine, the CNS effect, insomnia, headache, fatigue, and you can have the GI discomforts. These can also occur. Your patient can be encouraged and told that they continue and it will resolve. Usually these are mild anyway. The danicin, on the other hand, has been shown to cause pancreatitis, depending on the dose that is used. It could also cause neuropathy, peripheral neuropathy. It could cause hepatic toxicity. It could cause hematocytopenia. It has caused GI tract effect, diarrhea. It has caused headaches and irritabilities. These are CNS toxicities. Dalcitabine also causes peripheral neuropathy depending on the dose that is given. And in some patients, it could cause low levels of, peripheral neuropathy may appear, especially in a patient with low levels of vitamin B12. So cobalamin, low serum cobalamin can encourage peripheral neuropathy. So you can give the vitamin B12 as a supplement when dalcitabine is given. And for patients who are abusers of alcohol, that can also result in the peripheral neuropathy. All right. Dalcitabine can also cause pancreatitis, can also cause stomatitis, can cause ulceration in your esophagus. Stavudine also causes neuropathy, peripheral sensory neuropathy. This is also dose dependent, and it is actually the dose limiting toxicity. When this is noticed when you are using stavudine, that's the maximum dose you can use, and you may have to reverse it or change it altogether. Can also cause pancreatitis. It can elevate serum transaminases, implying liver compromisation. So that is the nucleoside reverse transcriptase, a few examples and how they act. Now, non-nucleoside reverse transcriptase, these are the ones we say directly inhibit the reverse transcriptase enzyme. So mostly these do not require the triphosphorylation to be activated before they can act, with the exception of efavirenz, which still requires the triphosphorylation before it can act on the polymerase. All right. Now, these non-nucleoside reverse transcriptase do not share common structure. In fact, their structures can be very diverse, but all of them directly binds to the enzyme and inhibits it. So let's take some examples. Again, remember the enzyme is the reverse transcriptase we are talking about, the one that converts HIV RNA to HIV DNA. And that's the enzyme that we are inhibiting. Nevirapine. Let's talk about nevirapine. Nevirapine structurally belongs to the dipyridodinium diazepinone structure, whereas efavirenz belongs to the benzoxazine. And you can see that the structures are very different, but both of them are directly inhibiting the enzyme, the reverse transcriptase enzyme. That's why we say they belong to a diverse, structurally different group. Now, nevirapine has been shown to be a very effective agent against the HIV virus. It can be used in combination with other HIV drugs for the therapy of HIV in both adults and in children. It's been used together with zidovudine to prevent mother-to-child transmission. Now, efavirenz, on the other hand, even though now its use is a little bit limited in Ghana, efavirenz, on the other hand, belongs to the benzoxazine chemical class group, also acts directly by inhibiting the DNA polymerase or the viral reverse transcriptase, which that's what we are looking at. It is an example of a DNA polymerase. Efavirenz, we are saying, is the one that needs to be converted into a triphosphorate form. It has to be activated before its activity. It's also being used together with other HIV medications for treatment of HIV in both adult and in children. It was one of the drugs that we were using for a post-exposure prophylaxis. We have changed the medications now. They're using lamivudine and tracitabine together. Not efavirenz, but now they are using dolutegravir together with lamivudine and tracitabine. So there's been a little adjustment, but it was a very good agent. Integrase inhibitors. Now, these drugs we are saying stops the HIV virus from integrating its newly formed DNA into the host DNA, into the host nucleic acid. Now, basically, once the DNA has been formed, so this is RNA polymerase converting to DNA. DNA can be inculcated into the host genome, and then it takes over and uses it for replication. But integrase inhibitors prevents the integration of the viral DNA into the host genome. So basically, it blocks the activity of the enzyme integrase. This we said we identify with the TEG. So ratigrave, dolutegravir. So the T is how we identify them. In Ghana, we are using dolutegravir. Then we have the protease inhibitors. Once the HIV virus has synthesized its, proteins, polypeptides, these polypeptides must be cleaved into smaller portions so that they can be assembled. That is done by an enzyme called protease. So we can also inhibit the enzyme protease. So protease inhibitors are drugs that inhibit the enzyme protease, and in doing so, prevent the assembling of the HIV viral proteins. These have been used for both HIV-1, HIV-2 infections. These are the ones we said identified by the NAVIR. So indinavir, ritonavir, saquinavir, lopinavir, etc., etc. If you take our protease inhibitors, we have them available as oral drugs. Their bioavailability is excellent if you give it orally. Indinavir, we say must be consumed on an empty stomach if you want to improve your absorption or have the best of absorption. Ritonavir comes in two forms, a soft gel or a tablet. Soft gel capsule must be refrigerated. The tablet don't need refrigeration. In Ghana, we're using the tablet. Protease inhibitors are currently being used for HIV-1 infection, and it is recommended that it should be used in combination with other agents like the reverse transcriptase inhibitors so that it delays the emergence of resistance. Common side effects associated with drug includes the GI side effects, gastrointestinal disturbances. It's been shown to cause circummoral paresthesia. It's been shown to affect the liver by increasing the aminotransferase levels, the enzyme aminotransferase levels. It's been shown to also increase triglyceride levels, and it alters the taste for some patients. There's evidence that if there is a resistance to one member of the protease inhibitors, the likelihood that the organism is also resistant to the other members of the protease inhibitors is high. So there is the cross-resistance among the protease inhibitors. There is cross-resistance among these class of antiretroviral agents. Also note that when you are administering ritonavir to people with impaired hepatic function, it's very important that you monitor or avoid it because of the fact that the drug can affect affect the liver anemically. Elevated hepatic aminotransferase levels is an indication of liver damage. So once the patient has an impaired function, if possible, avoid the medication. All right. If we take our HIV medications, we note that acyclovir, or if we take our antiviral medications, acyclovir, intracitabine, didenosine, saquinavir, ritonavir, are, according to the FDA pregnancy categorization class B, whereas the others are class C. Acyclovir, foscarnet, salcitabine, etc. are class C. All right. Thank you all very much. The Lord bless us all. The Lord keep us and cause his face to shine over us. You are blessed. You are blessed. You are blessed. Please don't forget to subscribe to the channel for more videos. Have a wonderful day.